Hello again, dear student. Hope that you are safe and healthy. So we are going to finish where we left off with the conduction system. So here we are going to talk about the part 2 of this big chapter of the heart, and we are going to talk about the intrinsic system of the heart and basically how the heart allows the contractions on its own. The conduction system is, we are going to jump to the slide where we left off. So the conduction system is a network of non-contracting cells and conducting cells. So it coordinates the heartbeat, and the heartbeat is function of the presence of the gap junctions. If you remember the cardiac muscles, we have those gap junctions that allow the transmission or facilitate the transmission of the action potential from one cell to another. They have those specialized, as I said, cardiac muscles that initiate and distribute the impulse from one region to another that stimulate the contractions. There are two types of myocardiac cells. Conducting system that controls and coordinate the heartbeat, and the contractile cells that produce contractions that propel the blood do not they do not need the nervous system stimulations. The conductions, it's similar actually to the action potential that we see in the neuro system during the anatomy physiology 24/1. When single contractions of the heart and all the cardiomyocyte contract as a unit, the entire heart contract as in series, first the atria, then the ventricles. And the way that the conducting system work is that the intrinsic conducting system work is that it began with an action potential at sinoatrial node and transmitted through the conduction system, produce an action potential in the cardiac muscle. And this we can actually detect those events, this electrical event, using an electrocardiogram that we will talk about it just a little shortly. So as I said, the way that this intrinsic conducting system work is that it began with an action potential at the pacemaker, more specifically at what we call a sinoatrial node. So let's talk a little bit about this action potential that has been generated by pacemaker cells. The cardiac pacemaker have an unstable resting membrane potential, MPA, membrane potential actions. They are three phases, three parts of this action potential. The pacemaker that is triggering the potassium channels, and they are one that is the pacemaker potential channels, and one they are triggering the sodium channels, and another one triggering the calcium channels. So the potential during the first part of the action potential, the potassium channels are closed. Let's forget that. Let's stop here just a little bit. Let me talk to you about how the membranes are. The membrane, I always call it, since I was a student myself, I always call it as a salted banana because it have a lot of potassium inside in the intracellular fluid, but they have a lot of sodium in the extracellular fluid. So this is the resting potential of the membrane. All right. So when depolarizations happen, depolarization happen how? By an influx of the sodium, huge influx of the sodium inside of the intracellular fluid or space. This will cause depolarizations. So during the first stage, the potassium channels, as I said, is closed. But the slow sodium channels are open, causing an interior to become more positive because potassium is positively charged, right? So it's going to increase the potential, the intracellular space to become more positive. And once they reach out during this depolarization, around we see around plus 30 millivolts. No, first around minus 40 millivolts. Sorry, they have calcium channels will open, and when this calcium channels is open, it's become like a positive feedback. More, he is going to trigger more calcium to come in, and this will raise the phase of the action potential. This is when it's going to reach plus 30 millivolt. So the influx of the calcium from the extracellular fluid trigger more calcium inside, and from where this extracellular calcium, from where this calcium is coming from the sarcoplasmic reticulum. It has from this source, right? It's going to be released. So this depolarization caused by the sodium is going to open the slow calcium channels, so the extracellular calcium channels coming from the ECF to the ICF, which is the intracellular fluid, causing like a positive feedback. It's going to stimulate the sarcoplasmic reticulum to release more calcium. And this release more calcium, it will increase the potential, action potential, at plus 30 millivolts. At plus 30 millivolts, the sodium channels will close, but the slow calcium channels remain open, prolongating the depolarization, as we can see as a plateau. That I will show you that, and this is very important, this plateau. I will explain it to you shortly. Just be patient with me. And then after that, the third phase of the action potential is repolarization. By the way, this calcium, this is slightly exactly the same, as I said, happening during the neural system action potential, but quite different, because during the neural system action potential, we don't have this extracellular calcium that is came in releasing calcium from the SR. We don't have that. The calcium is released only from the SR. Okay, so then after that, we have the phase 3, which is repolarizations after a short period, after 200 milliseconds. Slow calcium channels are closed, and the voltage-gated potassium channels are open, allowing the efflux of the potassium, and cells become more negative. They are getting repolarizing the cells to the resting membrane potential. The calcium is pumped both back into the SR and also outside of the cells into the extracellular fluid. All right. I really want you to look at this in general. I am really explaining it really in general and very, very easy way. All right. So this is exactly, let's look at it in this diagram. We have the 3 phases of the action potential, the cardiac action potential. of the muscle, cardiac muscle. So we have at minus 90 millivolt, this is the resting membrane potential. Sodium and the calcium channels are unclosed, right? And then after, a stimulus arriving to the SA, atrial depolarization rapid entry of the sodium that will came inside, you see it, it will came inside the intracellular space. That's the intracellular space, that's the extracellular space, and that's between, it's the membrane, okay? And then after that, when he reach around minus 40 volts, it will calcium channel, extracellular calcium will came inside, but once it reach plus 30 millivolts, it will stimulate the secretion of calcium from the SR. So this is very longer period, and this is what will be represented by the plateau, as we can see over here. This is the inflow of the calcium through the calcium channels that is entering more calcium, actually entering the remain open, making more calcium coming in, prolongating the depolarization, as we can see as a plateau. This about 200 millivolts. 200 milliseconds. After 200 milliseconds, rapid repolarizations. A rapid polarization is caused by the efflux of the potassium, and cell become more negative, repolarizing to the membrane to return to the resting potential. And during this period, the calcium channels is closed, and the potassium still open until he reach the resting membrane potential. This plateau represents what we call absolute refractory period. Refractory period, which is the interval during between the stimulus and then when all the calcium voltage channels stay open. So that represents the plateau of the calcium. So this is the refractory period. Action potential cannot be initiated no matter how large the stimulus is applied. And this stay almost like 200 milliseconds. As you can see here, after 200 milliseconds, repolarization starts until it reaches the resting membrane potentials again. And this longer refractory period, it's very good actually. It's very beneficial because it prevents tetanic contractions and also sustain the contractions. It sustains to ensure that we have efficient ejections of the blood from the ventricle via the systemic and the pulmonary circuit. So to make sure that the heart is not only contracting, but also he's playing his normal job as a pump for the blood. Okay. So let's talk about the specialized cells, the sinoatrial atrial node that exists in the wall of the right atrium. And then the junction between the atrium and the ventricle, we have the atrioventricular node Those are the pacemakers. And then after that, the parts of this conducting, intrinsic conducting system, we have also the conducting cells. Those are the SA and the AV node are the specialized contracting cells, and then the conducting cells, they exist through the cardiogram. Very specially, we have the internodal conducting cells that exist between the SA node and AV node, and we have also that exists mostly in the atrium, right, between the two nodes, and also we have in the ventricle we have two conducting cells. We have the atrioventricular bundles that exist in the septums that separate the both ventricles, and also we have bundle branches that they are left and right bundle branches. The heart, the SA node generates 80 to 100 action potential. It generates more action potential actually than the AV node. And the AV node generates 40 to 60 action potential per minute. And of course, I mean, we have the autonomic system that can influence this heart rate. The parasympathetic stimulation slow the heartbeat, while the sympathetic increase the heart. Okay. The cardiac cycle began with an action potential, as we just explained it at the SA node, and transmitted through the conducting system, produce action potential in cardiac muscles. Resting potential for the ventricles cells are around minus 90 millivolts, and the atrials it's about minus 80 volt. So this is just the PKG. Once this stimulus reach the PKG fibers, that they are going to distribute the stimulus to the contractile cells that is mostly made up of the muscles, the rest of the heart, the muscles in the heart. So let's look at the pulse conductions through the heart. In step one, as I said, there are SA node activity and the atrial activations began. All right, the SA node contain these markers, and they are connected to the AV node through the internodal pathway. So atrial activations start as a step one of this conductions, but it's not going to reach the AV node as soon as you reach the SA node. There are little delay. This little delay is very simple to understand because he starts at the right atrium. You have to reach the left atrium first. And once both atriums are being contracted, this is when he's going to reach the atrioventricular node that exists in the floor of the right atrium. In another word, it exists between the right atrium and the right ventricles. They are delay of the impulse. This is because you have to reach from the SA node to the AV node. They have a little delay, and this is because you have to reach the left atrium. So the atrial contractions, once it reach both atrium, SA node, both atrium, the atrial contractions begins. Here you go. Both atrium now are contracting. They are reaching after 100 milliseconds. They reach the AV node, right? They reach the AV node, And then after that, from the AV node, I love to look at this by pictures. After the AV node, they reach to intraventricular bundles, and then the ventricular bundles, they go to the right and left bundles, all right, reaching the Purkinje fibers, and went via the moderator band, so they are going to reach those Purkinje fibers. The elapsed time is about 175 milliseconds. Excuse me. And then they will reach after those right and left AV bundles branches. They are going to reach the Purkinje fibers, and those Purkinje fibers, they are going to distribute the impulse through the ventricles, and atrial contractions at this point stop completely. They are complete, and the ventricular contractions start after 225 milliseconds after the first start from the SA node. So in general, the SA node send the impulse arrive at the SA node. The SA node send it to the AV node. There are a delay over here because the SA node have to send have to wait for the left atrium also to get contracted. AV node, then AV node, AV bundle node, the bundle branches left and right, and then the Purkinje fibers, then the ventricular contractions start. So how we can looking at the heart, how we can look at the heart if he's working normally, how to measure the heart and see if it's working and beating normally or abnormally. We use a device that we call an electrocardiogram that can detect electrical current event in the cardiac cycle. We call that ECG, or that we give as a graphic actually, that we call it ECG or EKG, and all the you have to understand that all the action potential are all begin with an action potential or all at given time, not only at single action potential. And how we can detect those events that all the action potential they are given at one, not only at single action potential, is going to detect this electrocardiogram. It detects all the action potential that happen in the heart at given time, not only one single action potential. This is what I try to explain. And how we can detect or record those electrical events by the doctor will place an electrode at the special places in your chest, and it will record electrical events, and following that it will see if the heart is working normally or abnormally. So this is some quiz. So for example, if it's not working abnormally, this is the ECG. You can show some bradycardia, which is abnormal slow heartbeat, or tachycardia, abnormal heartbeat, and we'll take it from there. So let's see how the ECG, we can read the ECG. They are the features of the ECG that we can read on their diagram. We show P wave. Wave correspond to the atrial depolarizations. We have QRS complex, which is the ventricular depolarizations. And we have, I love to see it in a picture. So this is a graph. This is how we obtain from an electrocardiogram is this graph. So the P is show a wave, and we have a P wave that correspond to the atrial depolarization, and QRS wave that correspond to the ventricular depolarization and the atrial repolarization, and the T wave that correspond to the ventricular repolarizations. And the PR is the interval from the start of the atrial depolarizations to the start of the QRS complex, or the ventricular depolarizations. And we have the QT. The QT is from the ventricular depolarization to the ventricular repolarizations. And we have the ST interval, which is the entire ventricular myocardiography depolarization. This is a normal ECG. This is a normal ECG that show a normal reading or proper wave for level for each of this. And those ECG can tell me over here that this is a normal heartbeat. This is properly working, the heart functional properly and producing an action potential as it should be, and beating normally as it should be, and circulating the blood as it should be. So when it can show me some abnormalities, for example, here showing here, for example, fibrillations showing completely disorganized. We don't have any pattern. We lost this pattern, P, QRS wave, T wave. We lost it. And sometimes the T wave just happen soundly. So this is a premature ventricular contraction. So following the ECG, we can tell if it's the rhythmic cardiac cycle. Is it normal? Is it pumping the blood normal? Is it conducting, the conduction system, is it normal? Contracting normal? All this from the ECG. So in general, the cardiac cycle is the period between the start of the heartbeat and the beginning of the next, right? The blood flow during one complete heartbeat, and this include contraction, which is, we call that systole, and relaxation, diastole. Atrial systole and diastole are followed by ventricular systole and diastole. I represent series of pressure and blood volume change, and mechanical event follow electrical event seen as we seen on the ECG. So the cardiac, so let's look at this mechanical, more specifically, let's get started and see how more mechanical, those electrical events that happen that we seen on the ECG, how they are reflected mechanically in the term of contractions, relaxations, systole versus diastole. So these are the phases of the cardiac cycle: atrial systole, atrial diastole, ventricular systole, ventricular diastole. So let's get started about those mechanical events of the cardiac cycle. So the atrial systole began, right? That means depolarization triggers the atrial systole, which is the P wave. All right, right and left atrioventricular valves are open. All right, for those atrial contraction force or small, in relaxing, 80% of the blood is circulating passively from the atrium to the ventricle. But when the atrial depolarize, it forces 20% what is left of the additional blood into the relaxed ventricles, all right? And the atria eject the blood into the ventricle, filling the ventricle, Excuse me. And this, when the ventricles are filled, this is what they push the atrioventricular valve to be closed. The ventricle now contains the maximum blood volume, known as what we call end diastolic volume, that is at the end of atrial diastole, EDV. Depolarization, when the atrial systole ends, atrial diastole began, right? And this will spread depolarizations to the ventricle, causing the KRS wave. So this mechanical problem is the one that we are going to see as electrical in the ECG as QRS wave. The atria then finish contracting and return to diastole, relaxing, while the ventricle begins the systole phase. So during the systole phase, we have this first phase. So following the ventricle repolarization, which is the T wave, the ventricle relax, right? And the systolic volume, the blood remain in each ventricle after the systole. The ventricle pressure will drop, causing the backflow of the blood from the aorta and the pulmonary trigger, closing the semi-lunar valves. The ventricle are completely closed chamber, but momentarily, all right? This is referred to an easy volumetric relaxing phase. The ventricular contractions push the, as I said, the atrioventricular valves to be closed, but does not create enough pressure to open the semilunar valves. And during this pressure, in this period, this is what we called a volumetric relaxation phase. This is momentarily the ventricle is going to be a closed chamber. The AV valve are closed, and the pressure is not enough to open the SL valve. So the ventricle are momentarily completely closed chambers, creating what we call the isovolumetric relaxation phase. All right. As the ventricle's pressure arises, it will exceed the pressure in the arteries. And once it exceeds the pressure in the arteries, the semilunar valve, the SL valves will open and the blood is ejected. So this will allow the blood to leave the ventricle. The amount of the blood ejected is called what the stroke SV volume, right? Then the ventricle pressure is getting down. Semilunar valves are going to be closed. And what is left now in the ventricle, this is what we call the end of systolic volume, which is almost 40% of the end of diastolic volume that they got before. All right. As the ventricle relaxes, the pressure in the ventricle drops. The blood flow back against the caps, the semilunar valve, and force them to close. The blood flow into the relaxed atrium. because the atrioventricular valves are going to be open and passive atrial filling, and the system will restart again. The cardiac cycle, it's depend, of course, the heartbeat depend on several factors. I mean, they depend on the age, they depend on the gender, they depend on if you are sportive or not, on the body temperature. Usually 75% beat per minute, cardiac cycle lasts about 100 milliseconds. All the phases, if when the heartbeat is increased, all the phases of the cardiac cycle shorten, particularly the diastole, which is the diastole is the relaxation part, all right? The systole is the one that is the contractions part. So we can measure those, we can hear actually sound by placing a stethoscope for different sound pursued by individual valves. So when those valves open or close, they produce sound. So we have 4 heart sound. We have SA sound, that is loud sound produced by atrioventricular sound, and we have an S2 sound that is loud sound, also it produced by the semiliminar bone. So S1 and S2 correspond to the valve sound, and we have also other sound, the S3 and S4. They are very soft, and this is correspond to the blood flow into the ventricle and the atrial contractions. And the heart murmur sound is produced by regurgitation through the valve. So what we record by this phonocardiography, we record the sound created by the closure of the and opening of the heart valve and the blood flow. So we hear like loop, pop, dop, loop, then silence, dop, loop, little silence, dop. So let's look at it like the sound S1 corresponds to the atrioventricular valve closing, and the S2 similar semiliminar valve closing. So those valves are for the sound made harder in the cardiac cycle. And this corresponds to the ventricle and the atrial, to the produced by the valve closing. So so we have the S1, S2, S3, S4, and when the heart is, you hear like a murmur, that is a complete closure of the AV valve, atrioventricular valve. What is the cardiac muscles and output? Is the it corresponds to the stroke volume. Stroke volume, which is the end of diastolic volume minus the end of systolic volume that we see earlier during the mechanical event of the cardiac cycle, multiplied by the heart rate. And this, of course, as I said, this depends on the heartbeat, depend on a lot of factors, such as the age. For example, fetus, when I have my baby, when I was pregnant with my girl, at the doctor office, when the doctor listens to Kirli, her name, Kirli's heartbeat, it getting very faster, up to 160 beat per minute. And this declines with the age. The heartbeat also depends on if you are sportive or not sportive, on the body temperature. When the temperature rises, the heartbeat will rise, but also on other neurotransmitters such as acetylcholine. Acetylcholine, I mean, slow. Acetylcholine slow actually the heartbeat because I'm just verifying that I post that as a questions actually in the quiz because it opened the potassium channels in SA node and SA node cells and causes the pacemaker of the pacemaker potential to depolarize more slowly. So yeah, I hope that this is helpful and we can. I am here to answer any of your questions. We can set up a conference meeting to our Blackboard Collaborate Ultra. And hopefully I will see you for the next chapters. Thank you so much.